Good evening, dear doctors. Today we are going to conduct the second clinical episode on our XP Connect webinar education series powered by Logic Technology from GE Healthcare. Today we have a pioneer in the field of breast imaging, someone who needs no introduction. Please welcome Dr. Bijal Jankharia, partner, Picture This by Jankharia, Dr. Jankharia's Imaging Center, Mumbai. Dr. Bijal Jankharia has delivered several lectures in breast imaging in the country to radiology and many medical colleges. She is the Vice President of Breast Imaging Society India. She is the reviewer in the breast imaging section of IJRI for more than 15 years, and she is the Director of the Breast Outreach Program of IRIA in 2019-20. Dr. Jankharia has more than 25 years of professional experience in the field of mammography, breast ultrasound, breast MRI, and image-guided breast intervention. She has been trained at UCSD, Mayo Clinic, and Stanford in USA. Before we get started, due to nationwide lockdown, there has been a huge traffic load on the internet services. If you experience temporary interruption in transmission, kindly bear with us. We'll sort it out immediately and resume. I now welcome ma'am to address our viewers with a clinical talk on breast ultrasound. Ma'am, over to you.
Yeah, thanks. So, thank you GE for giving me this platform. And today we are going to be talking only about BI-RADS and breast ultrasound. It's not going to be an exhaustive talk on only ultrasound, but specific to BI-RADS. So the traditional use, and if you saw about 3 decades back, the main use of breast ultrasound was to differentiate between cystic and solid masses. And that's all people used to do. Cyst hai ki nahi, ya solid mass hai ki nahi. But now, especially since Stavros, and I presume most of you all who are doing breast ultrasound have that thick, fat book by Stavros, which is a really wonderful and an extremely detailed book on breast ultrasound. I would recommend everybody to just buy it and keep it in your department. But in 1995, he came out with this article in Radiology, which said that we can use ultrasound to distinguish between benign and malignant breast lesions, the solid lesions in the breast. Today, of course, breast ultrasound has grown by leaps and bounds, and we have high-resolution transducers, we have harmonic imaging, we have power doppler, we have elastography, we have 3-dimensional ultrasound, and we have this, which is automated whole breast ultrasound, which can automatically scan ultrasonically the entire breast from top to bottom, and we can see the entire breast in 3D. Today, we can use ultrasound for screening in dense breasts, as well as it is the main modality to do any intervention. So if a lesion is seen on breast ultrasound, we would love to approach it with ultrasound because the patient is comfortable lying down, the doctor is comfortable looking at it, and it is a live procedure. So it is amazing how ultrasound has helped us in doing all kinds of intervention. So breast ultrasound is a very, very powerful tool. It is extremely operator dependent, and I find it very difficult to get second opinions on breast ultrasound. I would rather never do it. It is a dynamic tool. We can assess lesion mobility as well as compressibility, and it allows us direct assessment of palpable lesions. So when a patient complains of a lump in the breast, all we have to do is hold it and put your probe on it. It is so useful that now BI-RADS has devoted an entire section to breast ultrasound. And I keep getting asked this, that, we did only an ultrasound, we've not done a mammo. Can we still give a BI-RADS category? Of course you can. And we'll be talking more about it throughout this talk. So BI-RADS is Breast Imaging Reporting and Data System, which is developed by the American College of Radiology, or ACR, and it took them 10 years to go from the 4th edition to the present 5th edition, which started in 2013. The whole idea is to give correct terminologies, to give correct assessment categories, and it should be uniform throughout the world. We should be able to issue meaningful and unambiguous reports. So in BI-RADS for ultrasound, there are 4 sections which go by general considerations. We'll be talking very little about this. We'll be focusing more on the lexicon as well as the reporting system. A few words about the basic anatomy of the breast. The breast is a very superficial structure, and the superficial fascia divides into a superficial and a deep layer within which the breast is encompassed. The basic unit of the breast is the terminal ductal lobular unit called the TDLU, which is like the bronchoalveolar unit in the lung, the basic unit, and it is from here that most benign as well as malignant processes are going to arise. The breast has several lobes usually, and each lobe will contain multiple such lactiferous sinuses opening out into the collecting ducts, and all this comprises one lobe, and most people will have about 8 to 20 lobes in each breast. They open as collecting ducts onto the surface of the nipple. The skin of the nipple and the areola is slightly thickened. The breast tissue actually hangs from the superficial layer of the superficial fascia with the help of these suspensory ligaments, also called as the ligaments of Cooper. And the entire breast rests on a bed of muscle, which is mainly the pectoralis major muscle. The beauty of ultrasound is we can see all these layers. So let's go on to the normal anatomy on ultrasound. The skin is 2 echogenic lines. Fortunately for us, we have alternating hyper and hypoechoic layers in the breast. So the skin is hyperechoic, 2 echogenic lines at the top. This is followed by hypoechoic subcute fat. Then is hyperechoic glandular parenchyma. Then is hypoechoic retroglandular fat. And then is muscle, which is hyperechoic. The Cooper's ligaments, they are seen as curvy linear densities going up to the superficial layer of the superficial fascia, which sometimes is seen as an echogenic band in the subcutaneous fat. And these extend from the parenchyma up to this layer of the superficial fascia. The skin around the nipple and the areola is thickened. We know that. The nipple gives rise to some amount of shadowing, as is seen here. If we want to look at nipple abnormalities, we can put a pad, a gel pad above the nipple to have a better look at it. And nowadays our ultrasound machines are so good that we can see normal ducts all the time. We really don't need to report them. They are incidentally seen all the time. When we are doing breast ultrasound, the patient is in supine position with the arm abducted and we scan in a radial manner. We can this way check out the superior, the medial and the inferior portions of the breast. To look at the outer quadrants as well as the axillary tail and axillary regions, we make the patient turn to the opposite side and then have a look on ultrasound. As far as ultrasound is concerned and settings for ultrasound are concerned, we have to use a linear transducer, preferably with a center frequency of about 10 megahertz. Scan without compression for ducts as well as for vascularity. And the grayscale should be such that the subcutaneous fat appears medium gray. It should never be black. We should have a machine which can get us into a trapezoid mode, which is useful for assessing large lesions. And most machines now do have it, as well as the extended field of view or the panoramic mode. which is again useful for assessing large lesions as well as for multifocal or multicentric disease, and we can actually measure the distance between the different foci of tumor in this patient. When we are documenting, we need to talk about the location of the lesion seen, and this is very useful even for the surgeon to know or the physician to know when they are looking at our films, as well as for us to know when the patient comes for a follow-up. So we should mention which breast, which quadrant, the clock face or clock position, the depth of the lesion, the approximate distance from the nipple. And if it is done for screening, then the minimum images that we need to take are one each quadrant and one behind the nipple. So totally about 5 in each breast, so 10 totally. As far as the location is concerned, I already told you, when we measure large lesions, it's a good idea to take 3 measurements, and we take images in the radial and in an anti-radial manner. When we take measurements and we document them, or when we are reporting them, we should take the longest horizontal first, followed by the anterior-posterior, and followed by the orthogonal horizontal. So in this patient, we are going to say there is a cyst in the right upper outer quadrant at 10 o'clock position, about 2 centimeters from the nipple, and it measures about 4.5 into 2.5 into 3.5 centimeters in size. Now the whole idea of doing any breast imaging is to differentiate between benign and malignant breast conditions. So we are going to be talking now about the signs of breast cancer, and that we'll be using the BI-RADS lexicon as well as the assessment category. If we look at the ACR BI-RADS, it tells us the lexicon to be used, and this is a lovely cheat sheet which anybody can download from acr.org, and you type in BI-RADS and you will get this. A good idea is to just print it out, and nowadays a lot of ultrasound people even have the BI-RADS software incorporated into the breast ultrasound machine. So in ultrasound is what we are going to be talking about today. It looks like a busy slide, but we are going to deal with it one by one. In patients of screening only, we should be mentioning about tissue composition, and then we talk about it as homogeneously fat. This used to be called as background echo texture before, but now it's called as tissue composition in the present BI-RADS. And this is homogeneously fat. So you can see fat all the way almost from the skin to the pectoralis muscle. This is homogeneously glandular, and this is heterogeneous. The glandular tissue here is pretty heterogeneous. We go on to primary signs of breast cancer, and these are masses, calcifications, and architectural distortion, mainly on mammography. On ultrasound, it is mainly masses, though we will talk a little bit about both these entities on ultrasound. When we talk about a mass, according to BI-RADS, we should be talking about all these. So we are going to be talking about them one by one. Shape. All the masses of the world, breast masses of the world, can be only one of these 3 shapes, which could be rounded or oval. By oval we mean ellipsoid in shape, but oval can also include gentle bi or trilobulations. Previously there was a word lobular that was used. It is no longer used, and if it is gentle bi or trilobulations, then we will give it as an oval shape, otherwise it would go as an irregular shape. So all masses shape has to be round or oval or irregular. The next important thing is orientation. By that, we already saw that lesions, the different layers of the breast, which were in a supine patient all in a horizontal direction, right? And usually benign lesions will follow that. If they don't follow, if they do not respect these boundaries, then they could be malignant lesions. So what we mean by orientation is if the longest axis of the lesion is parallel to the skin, then we are going to be talking about it as being parallel, and therefore it is more likely to be benign. However, if it is not so, then we talk about it as being not parallel, as simple as that. So in the talk henceforth, everything that is on the left side is more likely to be benign. Everything that is on the right side is more likely to be malignant. Then we go on to margins description, and when we talk about margins as being circumscribed, that means we have to see to it that all the margins are well defined with an abrupt interface between the lesion and the surrounding tissue. Then only we are going to be talking about it as being circumscribed. If it is not so, it is not rocket science. They are called as being not circumscribed. We can further differentiate not circumscribed as being indistinct. That means we don't know where the margins are ending and where the normal breast tissue is beginning. Angular, by that we mean that sometimes lesions have these acute angles forming. Microlobulated, there are several undulations here in the breast, and spiculated, which is quite obvious here. The straight lines which are going ahead from the lesion at its periphery. So when we talk about this lesion, we are going to be saying that it is an irregular shaped lesion in a parallel orientation with not circumscribed microlobulated margins. We also talk about the echo pattern, and so I've been talking about things as per importance. The shape, the orientation and the margins are the most important for us. The others less so. Anechoic means cystic, hyperechoic, so these two are usually benign. Hyperechoic means more echogenic. Isoechoic could go either ways, but when we talk about anything as isoechoic, it is in comparison to the subcutaneous fat, because everything in the breast will be hypoechoic if we compare it to the echogenic glandular parenchyma. Hypoechoic, more gray and black as compared to the subcutaneous fat. Complex, cystic and solid. By that we mean that it could be a cyst with an intracystic solid mass. It could also include solid masses with cystic components within it. And heterogeneous, where some areas are hyperechoic and some less so. So these are the words used to describe echo pattern in breast ultrasound. We also talk about posterior features. There could be none. There could be enhancement. This is more likely to be benign. There could be shadowing, more likely to be malignant, or you could get a mixed pattern in posterior features. Then, so this is all about the mass, and that is the most important part in breast ultrasound. We'll also talk a little bit about the less important stuff, and that is calcification. Now, calcification we all know are best seen on mammography, but in ultrasound, so you could have calcifications in a mass, outside of a mass, or intraductal calcifications. In a mass, they are very well seen on ultrasound. They appear as tiny echogenic flecks that do not shadow. but you can see how beautifully they are seen on mammography. And calcifications that are without a mass. There is a cluster of microcalcs here in the upper inner quadrant of the breast. This lady had just come for screening, and it is only because of this that we were looking in that area on ultrasound, and without an obvious mass, they are seen but are definitely less conspicuous. So these are microcalcs outside of a mass. This was removed surgically, and this turned out to be a ductal carcinoma in situ. So DCIS, which presents only as a cluster of microcalc, may be difficult to pick up on ultrasound. If seen on ultrasound and we don't have the means to biopsy or localize it with the help of mammography, we can attempt to biopsy it with this, and then it's a good idea to take a specimen X-ray of the core biopsies and check whether there are calcifications within it or not. Next we go on to associated features, and those are architectural distortion and several others. We'll be going through them. When we talk about architectural distortion on ultrasound, see on mammo, it is very nice to talk about. And I had just had a talk on it a few days back. But on ultrasound, it means that there is a lesion which blurs the tissue plane between the fat and the parenchyma. At the fibroglandular and fat interface, we know there is something that is going wrong here. And this is architectural distortion on breast ultrasound. It can also include a few other things. That means straightening and thickening of Cooper's ligaments. You remember the Cooper's ligaments I showed you earlier? For example, here, this is a Cooper's ligament. This is another one. But look at this one. It appears a lot thicker, and normally they could be a little curvilinear, but here they're just straight there. And there is a lesion here with architectural distortion at the parenchymal fat interface, and we can see straightening and thickening of the Cooper's ligaments, and this is also termed as architectural distortion. Other associated features are duct changes, and here we can see a mass that is extending into the duct, and this also has vascularity within it, as well as these ducts, when you try to compress, will be non-compressible, which tells you that this is not some debris within it, but actually there's a mass going into this duct. We also talk about skin changes, and it might be a good idea to compare it with the opposite side. So here we can see in the right breast, and we can measure it, as well as in the left breast. So more than 2 millimeters, except in the nipple areolar complex, where it could go up to 4 millimeters. If the skin thickening is more than 2 millimeters, we call it as being skin thickening. Other features are also edema. We can see on the mammogram that there is increased trabeculation, as well as skin thickening, as well as lymphadenopathy. All these are signs of edema in the breast where there is already a mass. But when we see skin thickening, as well as increased echogenicity of the subcutaneous fat, we had these alternate hypo layers. Here everything is continuously hyper-echoic, and that is a sign of edema. There is also an angular network of hypoechoic lines which represent dilated lymphatics or interstitial fluid. The causes of skin edema could be infection, as well as inflammatory breast cancer, mastitis, even congestive heart failure. Sometimes even following surgery and radiation, we may see some amount of skin thickening and edema. Vascularity in a mass is an important thing, especially if it is present. So in this case here, there's absent vascularity, we should get our technical factors set correctly, especially for low flow, and assist usually does not show us internal vascularity. If there is rim vascularity, then it is usually benign, like in the case of this abscess. And if there is internal vascularity, it could be malignant, but some benign lesions may also show it to us. Cancers usually show us irregular branching, and sometimes you see these vessels just going down from the center of the lesion, like it is seen here. Vascularity also tells us that the mass is solid. So in a cyst, if you are seeing vascularity, then better increase your gains, and then we might see a hypoechoic mass inside. Like in this patient, there's an intracystic solid mass which is showing vascularity. It looks like a stalk, and this helps us to differentiate from debris or a clot. And it can also act like, supposing this lady had two things which were protruding, and this one did not show us any vascularity, but this one does. So we know that for biopsy, we better target the one that is showing us vascularity. In vascularity, it is the presence of vascularity in any breast lesion which is much more useful than its absence. Next, we go on to elastography, and I'm sure all of you have elastography machines, and many of you keep on relying a lot on it. However, BI-RADS, especially the American College of Radiology, does not give a lot of value to elastography. I'll be talking about it just a little bit. Stiffness as a feature is based on the premise that cancers are hard and benign lesions are soft. It can be strain wave or shear wave, and here we can see that this nice lipoma is pretty soft, whereas this cancer is pretty hard here. And what is strain elastography? That means pressure is applied manually with a transducer, and the lesion deformation relative to the surrounding tissue is measured and displayed in color. We can have these scores, Tsukuba scores, and these kind of go quite a lot towards the BI-RADS. A few examples: the cysts may give rise to this trilaminar appearance, triple color artifact. Even a bullseye or a coffee bean appearance may be seen in cysts. And here we are seeing a mosaic pattern which is predominantly benign. This turned out to be a fibroadenoma. And here the entire lesion as well as the surrounding area is blue. And in this elasto machine, blue is hard and red is soft. So that is why this is very likely to be malignant. Of course, it's pretty obvious even on the 2D images. But please check the color coding and you can change it accordingly. And I wish all the vendors had very uniform color coding, where only one color was stiff and the other was soft, from red to blue. As far as strain is concerned, we can also compare and do a ratio of the lesion as compared to the surrounding tissue. This is a semi-quantitative method for strain elasto, and more than 3 could be suggestive of malignancy. Next, we go on to shear wave elasto, and that is, instead of using manual compression, it uses a shear wave which is created by a focused ultrasound beam, and this is measured and displayed with kilopascals or meters per second. This is a very good quantitative method which is highly reproducible, and it is less dependent upon the force that we have to give manually. And here we can see that the velocity is displayed in kilopascals or in meters per second, the cutoff value being around 80 to 100 for malignant lesions and 5.2 in velocity the velocity in meters per second. So in elastography, we also have to be beware because there are going to be false positives and false negatives. You're going to get soft cancers. You're also going to get cancers with necrosis within, which may appear soft on elasto. And we are going to get hard benign lesions, sometimes fibrotic lesions like fibroadenomas that are sclerosed are going to look hard. Radial scars are going to look hard. So please beware because these lesions do exist. The elastography features, according to BI-RADS, should not override the morphological features for patient management. The 2D features of shape, margins, and echogenicity are more predictive for malignancy as compared to elasto. I would rather use elasto to upgrade a lesion rather than completely downgrade it as far as BI-RADS is concerned. This is specifically mentioned in BI-RADS that inclusion in the lexicon does not equal to its endorsement of trying to differentiate a benign from a malignant lesion. Then we go on to certain special cases. A simple cyst is like a nice anechoic lesion, good posterior enhancement, thin imperceptible borders, and edge shadowing. Sometimes if there are low echoes within it, it might be a good idea to put on tissue harmonics. Most of them now in breast come with harmonics, so we can clear out the low level echoes, but then certain artifacts like posterior enhancement and edge shadowing may also be cancelled out, so beware about that. Now this sometimes confuses us. Clustered microcysts. Where is this word used? It means a cluster of anechoic lesions. Most of them are less than 2 to 3 millimeters. We can get these thin intervening septae within, and we can get lobulated margins because these are all individual cysts together, but there is no discrete solid component. Then we go on to complicated cysts. All these are mentioned in special cases. That means cysts with a thin septum or low level echoes, or sometimes mobile debris within it. All these are complicated cysts. Moving echogenic foci within is also complicated cyst. Mass in or on skin is again comes under special cases, and here we can clearly see on the skin of the patient there was a wart there. When we talk about dermal lesions, we should make out that most of the lesion is arising from our top 2 echogenic lines. This was just a dermal abscess. In foreign bodies, and we can talk about clits or wires, all these are special cases, but here we get the snowstorm sign of a silicone granuloma. This patient had explantation done, and this is what it appears like on ultrasound. Implants also comes as special cases. It's nice to do the panoramic or the extended field of view to look at it. And this is a collapsed implant where the entire shell is floating inside, and this is called as a stepladder sign on ultrasound, Linguini sign on MRI. Lymph nodes also come as special cases. This is a typical normal intramammary lymph node seen beautifully with ultrasound. It has an echogenic hilum as well as hilar vascularity within it. And these are usually seen in the upper outer quadrant, very often picked up just on routine screening, have not much of meaning whatsoever. And these are axillary lymph nodes. We call them enlarged, we call them significant not only because of the enlarged size, which does not have much significance, but because they have loss of fatty hilum or they have cortical thickening, especially if it's focal cortical thickening, or the entire architecture of the lymph node gets distorted. Special cases also includes vascular abnormalities, and here this patient had come actually with a palpable cord-like swelling in the breast. We can see it well on tomosynthesis, but on ultrasound we see this subcutaneous vessel-like structure without any doppler signal, and this is typical of thrombophlebitis of a subcutaneous vein, also called as Monbos disease. Post-surgical fluid collections like seromas are also coming in special cases. And this lady was post-surgery 1 year, and we saw this irregular lesion on ultrasound, which was nothing but fat necrosis, which is seen better on the mammo, looks a little suspicious on the ultrasound next to the seroma, and over a period of time we can see it calcifying there. As far as reports are concerned, we should talk about indication, statement of scope, technique, breast composition only for screening, but findings in order of clinical relevance. And very often I see that there are cysts that are mentioned all over in both the breasts, and every cyst being mentioned, and there are like 15 lines of cysts, and after that comes the suspicious lesion, which is cancer. So please go according to the order of relevance. Compare them with previous examinations, with the mammo, with a physical examination, and even mention that at the site of the palpable lump, we are seeing so and so on ultrasound. And then finally give the assessment category with the management recommendation. So let's go on to the next important part, which is the assessment category. When we talk about something as BI-RADS category 0, that means that the assessment is incomplete. And this for ultrasound is rare. It's more commonly used in screening mammo, where we need to go ahead and do probably an ultrasound of the breast. But this lady came to me for a biopsy. She did not really come to me for a BI-RADS category. But when I was examining her on ultrasound, she came for a complex cystic and solid mass biopsy. I noticed that there was a scar in that same area. So when I asked her if she'd been operated, she said, yes, last year, doc, it was a fibroadenoma, but this year I'm fine. And that lesion has gone out, but this is something new that has developed at the site of scar. So when I saw that, and if I had to give a BI-RADS category for this patient, I would give it as a 0, and then I would do a mammogram on her. And this is what we found, that it was nothing but an oil cyst or post-surgical fat necrosis due to the surgery, which is quite commonly seen. And then I would shift the BI-RADS from 0 to what I'm definitely benign, that is BI-RADS 2. So it's a good idea to ask for a mammography if it is required, if it is inconclusive on an ultrasound which is used for screening and we suspect that there is possibly fat within it. Or if it is a suspicious lesion in a young patient and we suspect that there are microcalcs in it. Then category 1 means everything looks normal, 0% likelihood of malignancy, it's a normal breast ultrasound. Then we go into BI-RADS category 2, which means that it is something that we've seen, but we are 100% sure that it is benign. So what lesions fall into this category? A simple cyst, definitely, BI-RADS category 2. Then this lesion, and now in lesions like this, it looks very, very benign, but a mammogram clinches it because this is nothing but a hematoma which contains fat as well as fibroglandular areas within it. And this is also called as a hematoma or a fibroadenolipoma or a breast within a breast, and this is definitely benign. This lady was lactating and complained of a lump in the breast. We did an ultrasound and we can actually see a fluid layer with the echogenic layer on top. When we turned her, it moved to that side, and this is nothing but a galactosele in the breast. We are 100% sure that it is benign BI-RADS category 2. This is nothing but an oil cyst in the breast. So on ultrasound, oil cysts look cystic, but if they have calcified margins, they are going to give rise to posterior shadowing. So these are cysts which are not going to enhance in the breast, and they are usually seen in the subcutaneous plane in the breast. Again, 100% sure it's benign, BI-RADS category 2. This 71-year-old male patient came with a lump in the left retroradiolary. And a few times we've been asked to just go ahead and do a biopsy. These are mentioned as irregular hypoechoic retroareolar lesions, maybe with speculations, and then we are asked to biopsy this. This is also a time when I will call it a BI-RADS category 0, and we'll do a mammogram and know that this is nothing but gynecomastia in the breast. I would definitely not biopsy this and give it as a BI-RADS category 2. So if we see what looks like glandular tissue in a male breast, if it looks like this on ultrasound, trust me, it is gynecomastia. And if we see several lesions bilaterally, all of them showing us benign features, multiple fibroadenomas bilaterally, then we would give it as a BI-RADS category 2. By that, it should be more than 3 total and at least 1 in each breast for us to call it BI-RADS category 2. The same works for cysts as well as clustered microcysts. I'll be coming to that. And if we see a lesion post-operatively at the site of scar which looks predominantly calcified, this is usually due to fat necrosis, and calcified fat necrosis we see very well on mammography. Again, BI-RADS category 2. Implants, BI-RADS category 2. Then we move to BI-RADS category 3. What does that mean? It means there's less than 2% chance of cancer. It is not expected to change over a follow-up. It does not mean that we are not sure what it is, and that's why we are putting it in BI-RADS category 3. No. We are 98% sure that it is benign, but we would like to keep a watch on it. And this has very clear findings on mammo, but on ultrasound it is a little bit sketchy and a little bit intuitive, and we'll be coming to that. In patients whom we get BI-RADS category 3, we would like to watch the lesions at 6, 12 and 24 months to prove its stability. So in ultrasound, there are 2 specific findings with very robust evidence, and one of them being, and this is a paper that came out in 2007, and mind you, all these words are important. A circumscribed solid oval mass in a parallel orientation. This lady had just come for screening, 46 years old, incidentally picked up this lesion, did an ultrasound, and look at it. Circumscribed solid oval mass in a parallel orientation. Fibroadenoma, very likely. Well circumscribed malignancy, less than 2% chance. So BI-RADS category 2 and BI-RADS category 3 and a 6-month follow-up on this patient. Isolated, look at the word, isolated complicated cyst. BI-RADS category 3, because they have a chance of malignancy about 0 to 0.8%. More than 0 and less than 2%. So they go on to BI-RADS category 3. However, if there are multiple and bilateral, once again, at least 3 and at least 1 in each breast, then BI-RADS category 2. Clustered microcysts, similar to what I had mentioned before, again, BI-RADS category 3. However, if multiple and bilateral, BI-RADS category 2. After 2 to 3 years of stability, the patient can't remain in BI-RADS 3 forever. The lesion may be changed to BI-RADS 2. But if the probably benign findings, for example, the longest dimension of a probably benign mass increases by 20%, then we would push it to BI-RADS category 4 and advise a biopsy. So next we go on to BI-RADS category 4. which has a wide range of malignancy. In ultrasound, again, we need not divide it into ABC, but a good idea to divide it, because then we can decide whether the concordance with the biopsy results is there or not. So let's go on to 4A, that means 2 to 10% likelihood of malignancy. This is a low suspicion of malignancy. So what comes in this? This 38-year-old female had a mother with breast cancer. This is the lesion we saw. It is not our circumscribed solid mass. It is circumscribed, but it is a little heterogeneous in echogenicity, and it is not oval. It has a few extra lobulations, which I am not going to accept in a patient who has high risk, and therefore BI-RADS category 4A. Look at the vascularity of the lesion, and we did biopsy it, and it did turn out to be a fibroadenoma in the breast. So 2 to 10% chance of cancer, BI-RADS 4A. This lady wanted only an ultrasound when she was 40 years old, and we've seen a lesion that is predominantly circumscribed, but it is heterogeneous. There are some cystic, almost serpiginous areas within it. It has internal vascularity. I'm not going to leave her alone at this. This would be BI-RADS category 4A. It's pretty soft on elastography, and this turned out to be pseudoangiomatous stromal hyperplasia, which can look like this. So there is concordance. Once she biopsied it, there is concordance. We know that it's fine. It could be a benign lesion. 35 years old lady, pregnant, and came with a palpable lump. Again, a little more heterogeneous than what I would like to see. Not willing to leave it alone. Not willing to say it's BI-RADS 2 or 3. Called it BI-RADS category 4A. We did an ultrasound guided core biopsy. Turned out to be a benign phyllodes tumor. She waited till she had delivered, and after that she got it excised. It was still a benign phyllodes tumor. Next we go on to 4B, where the likelihood of malignancy is a little more, 10 to 50%. And these are the conditions where we can use it. For example, when we look at a lesion like this, an intracystic solid mass with vascularity, this is our intermediate suspicion for malignancy. Could this be a papilloma? Yes. Could this be a papillary carcinoma? Yes. BI-RADS category 4B, this was just a benign papilloma, intracystic papilloma. This lady had come to us with what looked like a pretty benign looking lesion, but some fuzzy margins. Look at it on ultrasound. Pretty heterogeneous, good posterior enhancement. BI-RADS category 4B. This turned out to be a mucinous cancer in the breast. Lesions like this, rapidly increasing in size, heterogeneous on ultrasound with cystic clefts within it. Yes, we all know. Possibly phyllodes. This would be BI-RADS category 4B. We don't know whether it is benign phyllodes or cystosarcoma phyllodes. Benign, intermediate, and malignant is how phyllodes is divided. This was a benign phyllodes. BI-RADS 4B. Patient with a bloody nipple discharge, solitary dilated duct with an intraductal lesion, very likely to be a papilloma, but could also be a papillary carcinoma or DCIS with a papilloma. BI-RADS category 4B, and this was just an intraductal papilloma in the breast. Then we go on to 4C, where the chances of cancer are about 50 to 95%, which is high suspicion, and this is what we reserve our 4C for. Heterogeneous lesions, few angular, look at this classic angular margins and irregular solid mass in the breast. BI-RADS category 4C definitely looks malignant. This lady had just come for routine screening, but we did tomosynthesis on her and she had this speculated lesion in the breast. So we did an ultrasound, pretty small lesion, posterior shadowing, looks irregular, looks hypoechoic. We biopsied this and this turned out to be just a radial scar in the breast. This would go as BI-RADS category 4C. This lady had a palpable mass, but she's very dense, could make out a little bit of architectural distortion on mammo, but in dense breast, ultrasound is just fabulous, and we can clearly see this heterogeneous irregular lesion in the breast. And not only did we see this lesion in the upper outer quadrant, but we saw two more lesions in the lower inner quadrant. We did biopsy this. This turned out to be a multicentric invasive lobular cancer in the breast. This is BI-RADS category 4C. And ultrasound is far superior to mammography, especially in dense breast for multifocality and multicentrality, as well as for positive axillary lymph nodes. Then we go on to category 5, which is highly suggestive of malignancy, and this has very clear descriptors on mammography, but on ultrasound, if we see an irregular spiculated lesion with microcalcifications within it, we can call it as BI-RADS category 5. Then we go on to category 6, means that the lesion has already been FNA'd or biopsied. It's a known cancer, and it is usually used for, talking about response to neoadjuvant chemo. This lady had FNAC-proof cancer. This is the lesion. Looks very malignant, of course, but they are not asking you whether it's malignant or not. We need to know whether there's something else in the same breast or the opposite breast. If there is nothing else, then it would be BI-RADS category 6, which is known cancer. The 5th edition of BI-RADS has also separated, thankfully, the management recommendations from the assessment categories. So if it is 0, we know we have to do something else, compare with previous or do a mammogram. If it is 1 and 2, we are going to do regular follow-ups. If it is 3, we are going to do a short-term follow-up. And if it is 4 or 5, we are going to biopsy the lesion. But sometimes it so happens that we call it one category, but we still ask to biopsy. For example, this lady had a simple cyst in the breast, but it was painful, it was tender, and she said, please just do something about it. So we give it as a BI-RADS category 2, but we are going to recommend an aspiration if the patient wants it, which we do. The 5th edition also tells us that compare with previous studies, compare with other modalities, and then give a single combined assessment. We are not going to say BI-RADS 2 here, BI-RADS 2 in the left breast. We are going to talk about BI-RADS category 4C in the left breast, which is the final category of the patient. 3, 4 and 5 cannot be used for screening, only after a full diagnostic workup. And with that, I'm finishing my talk on BI-RADS. It is an evolving document. We're teaching and learning at the same time. And with that, I hope most of you are working from home, but if you're getting out, please take care, please be careful. And that's the end of my session on BI-RADS. So I'm going to, should I pause my share here, screen share here? Hello? If anybody has any questions, I'm happy to answer them.
Ma'am, Rupesh here. So first of all, thank you so much for coming. Okay, and yes, without wasting your time, definitely the presentation, what you had prepared was fantastic, and I hope probably it was really good with real-time case studies for the viewers also. So without wasting time, ma'am, we have close to 30 questions. So I'm going to read one by one, so you can try to give your answers, ma'am. So the first question was, BI-RADS 3, how can you diagnose and manage?
So I already told the conditions when we do a BI-RADS 3. That means a circumscribed solid mass in an oval shape, or that means a parallel orientation. That is the time. Or an isolated complicated cyst in the breast. These are the times when we give BI-RADS 3. and management is with a 6-month follow-up. So if it is seen on mammo as well as on ultrasound, we are going to do a follow-up with both mammo as well as on ultrasound. If it is a young patient and it is just a complicated cyst, then we can continue only with ultrasound.
And the second,
On to the next. The management.
whether
Yeah. One more thing I'd like to add to this, Rupesh. So when we are doing the first follow-up, when we do the first 6-month follow-up, and if we are doing only an ultrasound follow-up, if it has increased in size more than 20%, then we are going to put it as BI-RADS category 4 and biopsy it. But if it is stable, then we are going to do it at 12 months again and at 24 months again. And at the end of 24 months, if it is exactly like what it was when we first saw it, then we would push it into BI-RADS category 2. I hope that answers the question. Yeah, Rupesh, carry on.
So the second question is whether FNAC is must in every breast mass.
Not really. If you see just a cyst, we don't need to do anything. And first of all, these days we hardly ever do FNAC. The only time we do aspiration is when it is a large cyst which is really discomforting to the patient. That's the only time when we actually aspirate it. Otherwise, we just do a core biopsy of the breast. And it is not required. So we would do it only in our BI-RADS category 4 and 5 lesions. And I showed you many of them in this talk. That's when we are going to be doing a core biopsy. Next question, Rupesh.
The next question would be, in some books it is mentioned that the position of the patient to be supine with the examining side to be elevated by some degree.
So I don't really elevate the patient, but when the patient is turned to the opposite side, it's a good idea to put a small pillow on the same side when you're looking at the outer quadrants. But otherwise, elevation is not really required. At least I have not been using.
Okay, thank you, ma'am. So significance of ductal enlargement or ductal ectasia.
Yeah. So now this is a question that is usually always asked. So remember, today's topic was only on BI-RADS, right? But let me answer this for you. It is very clinically oriented question. So if there is a spontaneous bloody or a serious discharge, and if we are seeing either a solitary dilated duct or multiple dilated ducts, then it would go as BI-RADS 4. However, sometimes, with our high resolution machines that you guys provide us, we can see normal ducts quite often. And if we see mobile echoes within them also, we see that quite often. And if the patient has no complaints, I seriously wouldn't even mention it. The normal diameter of the duct depth is supposed to be around 2 mm, and more than that is considered as ductal ectasia. If you want, you can report it, and if it is bilateral and multiple, just call it BI-RADS 2. However, if the patient has any complaints regarding it, and if you see a solid mass within it, if you see vascularity within it, if it is just one solitary dilated duct, then we would call it as BI-RADS 4, and we would do something more about it. If we can see it well on ultrasound, we can do a biopsy. If not, then a hook wire localization and a surgical biopsy. But if we are seeing just one dilated duct and nothing within it, then we are going to advise an MRI or a elastography. We will take all the pains possible to trace the duct as much as possible with the help of ultrasound. And here I would also like to add that keep a very light hand on the transducer. Because if you're going to put your weight on the transducer and try and figure out, is there something, and I've seen that happening, people staring and looking at it, by then the duct has already emptied out from the nipple and it has collapsed and it is very difficult to make up. So just keep a light hand when you are examining ducts. Just keep a light hand on the transducer. Okay, next Rupesh.
Ma'am, how to report fibrocystic disease of breast in USG and X-ray mammo?
Wait a minute. So, microcyst is an ultrasound diagnosis. On mammo, you might see a well-circumscribed lesion. In patients of dense breast, you may not see anything at all. But if you are doing both together, so it's a combined report together. So, if there are just 1 or 2 microcysts, we are going to give it as BI-RADS category 3. If it is seen only on ultrasound, then we follow up only with ultrasound. But if we are seeing multiple, bilateral, at least 1 in each breast, then we are going to give it as BI-RADS category 2. Not worry about it. The patient just comes for a routine 1-year follow-up. Okay, next one, Rupesh.
Ma'am, what to look in case of galactoria?
So we are just going to be looking out for ducts. And if there are dilated ducts, we just mention them. But otherwise, it really doesn't have much significance. You should ask the patient to get a prolactin done. And if it is raised, then she'll be put on treatment for that. That's it. Okay, next, Rupesh.
The next question would be, what is the difference?
Yeah, Rupesh, one more thing. We need more of BI-RADS ultrasound oriented questions, But anyway, just carry on. Yeah.
So what is the difference between enhancement and shadowing?
So there is a lesion, right? Which is gray, black, whatever in color, whatever in shades. But behind the lesion, if you see white, that means it is enhancement. Behind the lesion, if you see dark, that means it is shadowing. Like how we see our own shadows when the sun is shining on us. You see a black shadow, right? So that is shadow. And if we see something bright beyond it, it is enhancement. Next one, Rupesh.
Thank you, ma'am. So what BI-RADS if architectural distortion, intraductal solid lesion / edema?
Oh my God, that is a lot of questions. So architectural distortion would be BI-RADS 4. Next one was an intraductal solid lesion would be BI-RADS 4. And the next one would be edema. So if there is something that can explain the edema, if there is axillary lymphadenopathy, if there is a malignancy, edema per se would not have a BI-RADS. There has to be a cause for it. If you have found a cause, if it is infective, if it is neoplastic, whatever, then the BI-RADS would go according to that. So that would be a BI-RADS 4 usually till you find a cause for it. Okay, next one.
Thank you. The next question is, what BI-RADS if asymmetric density on mammo, on sono, no definite lesion?
Okay, so now asymmetry on mammo means it's a single view asymmetry. It is seen on one view, not seen on the other view. The way to sort it out is not really ultrasound. The way to sort it out is by mammo. You will call the patient back, you will take a spot compression, or you will take a rolled view and have a look at it. If you've done tomosynthesis, that should help you sort it out. If we go on to the next step, which is focal asymmetry, that means it is seen on both views. So, by the way, that asymmetry would be BI-RADS 2 and we forget about it. We are not worried about it. You can even give it as a BI-RADS 1 if you have sorted it out on mammo. Ultrasound invariably does not show us anything in case of single view asymmetry. If it is seen on both views, then we label it as focal asymmetry if it is less than a quadrant. And then we would do an ultrasound and check out that area. And if there is something like thickened glandular tissue, Then we would give it as a BI-RADS 3 and ask for a follow-up, 6-month follow-up. However, if there is something more, if you find that there is a mass in that area, if there is some associated architectural distortion, then it would go as BI-RADS category 4 and we would ask to biopsy it. I think that answers it, Rupesh.
And the next question is how to differentiate between simple cyst or any other infected or oil cyst.
Okay, so a simple cyst, first of all, you don't need to differentiate a simple cyst from an oil cyst because both of these are BI-RADS category 2 and we are absolutely sure that it is benign. So in a simple cyst, it is completely anechoic, nice, thin rim, imperceptible walls, no echoes within, no solid masses within, no enhancement, no vascularity within. It might show us edge shadowing and it might show us posterior enhancement. That is simple cyst. Complicated cyst means that there could be thin septae within, there could be some low-level echoes within, there could be mobile echoes within, there could be shifting fluid debris. Complicated cyst. Isolated, BI-RADS category 3. Simple cyst, BI-RADS category 2. Complex is when it could have thick septae, thick irregular walls, or a solid component within it. May show vascularity within it. Complex cysts are BI-RADS category 4. So simple, BI-RADS 2, complicated, BI-RADS 3, complex, BI-RADS 4. Next one, Rupesh.
What BI-RADS needs multiple well-defined hyperechoic areas are seen in both breast, which look like lipomas, but there is...
I lost you there, but there is... Hello?
Ma'am, I will repeat it.
Yes.
Can you hear me, ma'am?
Yes,
Can I
yes.
repeat it?
Yes.
So what BI-RADS needs to be given when multiple well-defined hyperechoic areas are seen in both breast, which looks like lipomas, but there is no palpable.
So, you know what? If you mention it and you are showing them on ultrasound and you are saying that, okay, this quadrant, this lesion, subcutaneously echogenic, looks like a lipoma, BI-RADS category 2 is the BI-RADS that you would give for this, only if you're mentioning it. You can even choose just not to mention it, not to document it, and say there was nothing in the breast. Then you would give it as a BI-RADS category 1.
Thank you, ma'am. So the next question would be, in case of fibroadenoma, so what is the BI-RADS category we should give, and should we do FNAC in such cases?
First of all, FNAC is a big no-no. So let's go on to the clinical scenario. Supposing a 45-year-old lady came to us with an came to us for a routine screening, and we found something which is oval, nice, round, homogeneous, with good posterior enhancement, very likely to be a fibroadenoma. Then we would give it as a BI-RADS 3, not required to biopsy at that point in time. This is the first time we've seen her. Just follow her up after 6 months, 12 months and 24 months. In younger patients, it is even in spite of being palpable, if it looks like a typical fibroadenoma, then we can still give it as a BI-RADS category 3, though it is palpable. Remember, in an older patient, if she is above the age of 40 and if it is palpable, it will go as BI-RADS category 4 and we need to biopsy it. If she is younger, then we can wait and watch, again put it as BI-RADS category 3, 6 months, 12 months and 24 months only if it is very classic. However, if it is heterogeneous, if it is showing us some small lobulations, very much increased vascularity, some cystic areas within it, we are going to put it as BI-RADS category 4 and biopsy it. Okay, next one, Rupesh.
So the next question would be, should a normal breast ultrasound be always assigned a BI-RADS category?
So we need to give a BI-RADS category only if we have done only an ultrasound. If we have done a screening ultrasound, which we almost never do, right? So then we need not assign a category. Then we assign a category what we have done with mammo. However, if there is something abnormal, then we give a combined category. Now, in patients who are, say, young patients and who have got their whole breast ultrasound done, because she is dense on mammography, she also got a whole breast ultrasound done, which is now approved for screening in patients with dense breasts. And it's normal. Then 6 months later, she again comes, this time only for a screening ultrasound. You could even do a handheld ultrasound. And if it is normal, then I would give it as a BI-RADS category 1 and say that there is nothing abnormal seen on the breast ultrasound. So normal ultrasound or anything in ultrasound, you can give categories to it exactly as I mentioned in the last 1 hour. Okay, Rupesh, next one.
And the next question is, what is the role of contrast as far as ultrasound breast is concerned?
So this is really not my thing right now, and maybe once more when you have an ultrasound lecture, there are many people who are doing contrast enhanced ultrasound. I'm not really doing it, and I don't see much about it. Also, BI-RADS is not really mentioned much about it on breast ultrasound. Okay, next one.
Okay, ma'am. And the last question for the day would be, what is the criteria for macro calcifications and micro calcifications? Is there any size criteria?
Hello, this is a mammography question. It is not really an ultrasound question, but micro and macro, there is a size criteria which is there on mammography. Less than 0.5 and inner cluster is cluster of microcalcifications. However, in macros, it is actually very eyeballing, and I would do it that way. If it is a large chunky calcification, it is macro. If they are small, tiny echogenic foci, say within a mass on ultrasound, then these are microcalcifications. As simple as that. But less than 0.5 mm in size, if you are going to be actually measuring it, is called micro. Okay.
Thank you, ma'am. And I have another last question. Okay. Is in USG guided biopsy, do you give a nick with stab blade always, sometimes, or never?
So depends on what needle you are using. You know, if you do it with 18 or 16 gauge needles, ideally they all should be done with 14. If you give a slight nick, it's a good idea. But if you're doing with 16 and 18, I just put in a small needle of the same size just to create a path, and that's enough. So
I think
that's the end.
And the question and answers. So again, thank you so much for coming in and presenting a wonderful presentation.
Thank you again, G, for giving me this platform. And I had a great time. Thank you. Bye.